Good afternoon, everyone. Welcome to this session, which is entitled Examples and Special Considerations for Delivering Value-Based Healthcare in Resource-Limited Settings. I would like to ask, if at all possible, since this is a gargantuan room, if those of you who will be joining this session, please come a little bit closer to the tables that are nearer to the front. That would be much appreciated. So my name is Neo Tapela. I am Chief Scientific Officer at ICHOM. I am a physician and an epidemiologist by background and have worked in health policy and planning and delivery of innovative patient-centered care in various settings around the world, including in Rwanda and my home country, Botswana. Value-based patient-centered care for all, including patients and people and communities in resource-limited settings, is something that's near and dear to my heart. And so it's for this reason that I'm particularly overjoyed and honored to be moderating this session this afternoon. There are two key motivations that have led to this session. And the first is that there's a change in the landscape such that people and communities have higher expectations of health systems around the world, including in developing countries. We're no longer expecting to merely survive childbirth or conditions such as HIV or COVID, but the expectation is that you have long, high-functioning life long thereafter, and that survivors are thriving members of the society. I think also when you look at the conditions that predominate today, it's in the global south, it's no longer infectious and nutritional conditions alone, but you are seeing non-communicable diseases, mental and behavioral conditions, trauma, and other conditions emerging as priorities as well. So this changing landscape is really what has required us, be we citizens, care users, policymakers, payers, and other stakeholders to relook at health systems and transform them in a way that better responds to needs of people. The second motivation for this panel is that while it is developing countries that particularly cannot afford to deliver low-value care, the attention and the efforts around this transformation have tended to focus on developed countries. So there's a need to shift this imbalance and to shine a light on examples of high-value care models that exist in resource-limited settings, to show that they exist, but also to share some of the insights that have resulted in the success of those models. And to do just that with us today are our three distinguished panelists who are visionary leaders in value-based care working in nonprofit, private, and social enterprise sectors. And they are delivering high-value, laudable care in South Africa, in Kenya, in India, and beyond. And we really look forward to hearing their take on what it's taken to deliver these care models, what the challenges are, and takeaway lessons that can inspire and really help to accelerate this global movement that we're a part of. So we have first Dr. Nicole Speaker. Dr. Speaker is CEO of Farm Access, an international nonprofit organization with a mission to improve access to affordable, quality healthcare for low-income groups in sub-Saharan Africa. She has 17 years of on-the-ground experience in sub-Saharan Africa, and under her leadership, Farm Access achieves its mission through an array of initiatives such as co-developing low-cost insurance platforms, providing implementation support through Safe Care, and developing Mom Care, a patient-centered, digitally enabled care bundle for mothers and their babies. And this you'll hear more of directly from her today. Next, you'll hear from Dr. Bishnu Panigrahi in the center. He is Group Head for Medical Strategy and Operations at Fortis Healthcare, one of the largest healthcare providers in India. He's an anesthetist by training with specialization in cardiac and neuroanesthesiology and critical care. His illustrious career includes 12 years in academic leadership and healthcare administration. Dr. Panigrahi spearheaded successful implementation of ICHOM sets for coronary artery disease at Fortis, making Fortis one of the first organizations in India to measure and benchmark health outcomes. And last but certainly not least, we have Dr. Shintan Maru, who is founder and CEO of Leapfrog to Value. He's a Johns Hopkins trained medical doctor and public health expert who has dedicated his career to maximizing the value of health systems. He served as a public policy and international affairs fellow at Princeton, a US Fulbright scholar to Jamaica, and a consultant at McKinsey, transforming health systems in the US and in sub-Saharan African countries. We'll hear from him some of the exciting initiatives at Leapfrog to Value, including designing value-based payment models and learning collaboratives focusing on the Global South. Again, I'm ever so thrilled to be among such distinguished company today, and thank you for making the time to join us, and we really look forward to the rich insights and perspective that you'll bring to the discussion. I want to mention, finally, before I hand over to the panelists, that we'd really love for this to be as interactive as possible. So if you're joining here with us physically, please, after 5 minutes contributions by each of the panelists, I'll follow up with 1 or 2 questions, then open up for questions to the audience. So be ready to raise your hand and a roving mic will come find you. And if you are joining virtually, we're also keeping track of the questions that come through the chat box in the webinar, and we'll filter them through there as well. So with that, let me hand the floor over to Dr. Speaker and ask her to share with us what high-value care means to you and what you are doing to deliver this for women in Kenya and beyond.
Thanks so much, Neil. And first of all, thanks for the organizers to invite us here today to share our work. I see this session is called Delivering Value-Based Healthcare in Resource-Limited Settings. But to quote our founder, Joep Lange, that basically every country is resource limited when it comes to healthcare. It's just the amount of money that you're talking about that differs. So really starting by advocating that we should consider value-based healthcare in every country, especially in lower income countries where outcomes are even more devastatingly poor than some of the examples that we heard this morning. So our organization is on a mission to change that and to use innovative digital approaches to improve quality of care. And a big part of that is really to develop better healthcare for women and children. That traditionally is, maybe if you can go to the next slide, Neil, thanks. That is delivered in healthcare facilities like this, very basic healthcare facilities where women access healthcare services and deliver the baby. Now, traditionally, these healthcare facilities are financed through what we call supply-side financing, meaning that the government ensures that there's medication and staff and services, but in practice, that is very often not the case. So many are on a transition towards universal healthcare financing, where financing mechanisms such as insurance are an approach to improve on this care. And we've taken steps to introduce the concept of value-based healthcare to bring from the supply-side financing to a demand-side financing mechanism where women are empowered to access these services based on value. We've predetermined and pre-costed the quality and financial model of a pregnancy journey from the time of pregnancy till about 3 months after delivery of the baby, so included the vaccination, and made an agreement between the patient and the healthcare provider to go on this journey. The payments are bundled on each visit, but there is also an incentive to complete the journey, which we know is a proxy for good health outcomes. If you do your ANC visits, if you do your hospital-based delivery, if you do the right tests along the care journey. But we've also digitalized the whole approach. So every time the healthcare provider and the patient get little nudges to tell them that to tell the women that they should be going to the hospital, to remind the doctor that they maybe forgot to do an essential test or they need to prescribe certain medication according to the risk profile of the women. We've been able to demonstrate with this model that, for example, we've done 50,000 journeys now in Kenya and Tanzania. In Tanzania, for example, we've been able to go from a 34% journey adherence at the beginning of the program to an 81% journey adherence at the program where we are now. So these financial incentives really stimulate better journey adherence for women and their healthcare providers in low and middle income countries that work way better than just delivering the medication and hoping for the right services to be done. We've incorporated ICHOM standards in this approach, so also measuring prompts and asking the women how they experienced the journey, as really not only making sure that the care was adequately provided in, but also outside the journey. I'll cut it a little bit short because I recognize that I'm going over my first 5 minutes, and I'm sure these topics will come up. But one of the things that we've noticed from our first experience is that, first of all, the data collection mechanism needs to be very innovative, using platforms that are already there, like SMS services, because a lot of people in Africa do not have a home address, and you cannot send a letter there and ask them questions. But most women will have a mobile phone and things like that you can utilize at very low cost to connect with the women. The second part that we've learned is that although the ICHOM standards were very much applicable, you definitely need a more compact set of questions to ask, but most of them are already relevant for the doctors to improve quality of care. And also some of the sort of social questions related to the interpretation of the ICHOM standards are different in a very different social cultural setting. That are some of these lower income groups, especially in slum areas, where women simply are facing a different reality than some of us who are born and raised here in Boston. So some early learnings, and really looking forward to the panel discussion today.
Wonderful. Thank you so much, Dr. Speaker. Moving over to you and moving to the Asian continent, perhaps, and thinking about a different disease area, if you will, cardiovascular diseases. Can you share with us how you've defined high-value care in Fortis and how you're transforming healthcare towards that definition?
Yep. First of all, I'd like to thank ICHOM and thank the organizers for organizing a very nice meeting. The sessions have been very interactive, good sessions. So I'd like to just say that one decade has gone by, and from Fortis, we were one of the early adopters of ICHOM standards, and we were fortunate to be part of the working group which developed the standard sets for coronary artery disease. So we had the benefit of having a hospital in Delhi, which is one of the largest heart centers in Asia, probably the world, which does upwards of about 300 surgeries a month, about 350 angioplasties a month. And the doctors there are Indian trained from UK, USA, so a good bench of doctors we had there. So keeping that in mind, when we had the standard sets rolled out in November 2012 by Professor Michael Porter here in Harvard Business School, so we went back. This very important thing I'm saying is that for 2 years, in 14 and 15, we did the piloting in our main hospital, and then we rolled it out in 2016. Next slide. So in February of 2016, Fortis Healthcare was the first one to publish clinical outcomes, and the basic purpose was to how do we go for patient empowerment and have safety standards. And it was again adopted on the global ICHOM benchmarks. So going forward, if you look at it, we started the journey in 2012-13, 14 we piloted, and 16 we rolled it out. And after that, we have kept on looking at all our CED outcome measures, whether it is CBG or PTCA. And over the last 5 years, we have been doing it. And this is the data set that we have from 2016 to 19. It is the CABG, you can see it, the average, annual average. And all these have been sort of validated internally by the senior clinicians. We also have something called an internal external audit. Suppose this is this hospital, someone from this hospital will come and audit that. Because at this point of time, we don't have a national audit mechanism to look at outcomes data. So this is something that internally we did. So if you say that there's no bias, at least as far as practical, it has been avoided that way, because when someone from outside comes, they look at it and see the data. The 2021-22 was practically a black hole because of the COVID. But the data has been captured, but we are not validated. And hopefully by the end of this year, that should be validated, and we'll be publishing it on our outcomes in our website. So we've gone ahead and done that. All our CAD data is published, validated, and put on our website. And as we speak about this, we've also looked at our total knee replacement data. We captured the Oxford knee score, knee society score, and the volumes are good. So it's a nice way of looking at it with good outcomes. For kidney transplants, we look at 1 year graft survival, which is a very standard landmark that started first in USA, to see that where your graft survival is there for at the end of 1 year, because that's a very important way to look at whether your transplants are really doing well or not. And the other thing is that endoscopic, the ERCP, the endoscopic retrograde, the test that we do, which is a very common thing by the gastroenterologist, but it has a lot of complications. So just to see that we are doing the right thing, we started capturing our ERCP data, and this is what we have been doing. And so this is I'm sharing the data for the coronary artery bypass graft and the PTCA graft. Because there's no Indian benchmark to it, so we picked up the US Heart Registry, the Cleveland Clinic, DexSart, and sort of benchmarked it. And if you look at the CABG where we are, and so we have practically properly benchmarked with global standards, as Stephen in the morning was saying. It is, when we started looking at data, we found that even in developing countries, outcomes have been good. So it's a very nice thing that has happened, because if you look, data also gives you a way of looking at it. While we're doing this, I'll just share it. On a monthly basis, we pick up this data, we give it back to the hospital where it happens. So interestingly, I'm just sharing something. The internal mammary graft, which is put on the LAD, is a gold standard. In one of the hospitals, it was not that 70% plus, it was lower. And all clinicians are smart. So when they have looked at the data, they must have found that something is not right. And slowly we found that they upped the thing, and it was doing well as far as global standards. Even the PTCA, we are looking at it. Looked at all the good the parameters as far as the ICHOM benchmark are concerned. That is there. Coming to the next one. We started doing our prompts. So what was happening is to send the emails at the time of discharge, but that was a black hole, to be honest. No one is to respond to the mails. So I'm just being honest with this, a learning that we had, we suffered. So then we had to think out of the box. So what we did, we started using a patient experience resources. Because the patient experience resource is attached to the patient, or becomes the mentor-mentee system that we have, right from the admission of the patient till discharge. So before discharge, this patient experience officer tells the patient that after you reach home, we'll be interacting with you at regular intervals to assess your functional status. So for the CAD, we had this which was developed, the Seattle Angina score and the Rose dyspnea score, which gives you the functional status of how the heart is behaving. And PHQ-2 is the public health questionnaire, which is actually 9, but when we did the standard sets, we brought it down to 2, because it gives you the mental status of the patient, the psychological status of the patient. Because a lot of times patients have surgery or a procedure, but functionally they're not right, which is not right. So this is what we did, and it's the standard sets, we customized it to the prompts in our layman language, which common man can understand. So we call it kindergarten language. And it gives a very nice insight. So this we have started capturing. So this is how we have gone about our journey.
Wonderful. Thank you so much for sharing that, and it's wonderful to sort of hear your perspective as somebody who was at the table in the working group developing the set and then implementing it at such scale in India. Thank you. So moving on to Dr. Maru, and I know this is as somebody who has worked across continents and also having engaged particularly payers as well as providers and other stakeholders. Please share with us what your take is on high-value care and how that has looked through Leapfrog to that.
Yeah, sure. Thanks, Neho. The thesis that motivates a lot of our work is this idea of a leapfrog. I was working a few years ago as a consultant doing a lot of US-focused, global north-focused, value-based care work. We were trying to dismantle a system that focuses and incentivizes volume. And at the same time was in another half of my career working with health systems in South Asia, Sub-Saharan Africa, and realized that there was a bit of a disconnect, that we were actually building up the same kind of systems we're trying to dismantle elsewhere. And so this idea of a leapfrog is, how might you, in a system where the market norms, the infrastructure, the systems are not entrenched in a certain way of doing business, is this possibility of a leapfrog possible? And these two examples that Nicole and Bishnu offered are awesome, and they are the starting point for which we hope would be a broader movement. And so our approach over the last couple years has been, how do we create a platform that's gonna move the movement together stronger and faster? And so what are the elements of that platform? We're trying to build partnerships that advance more and better innovation, so bringing payers like these national health insurance schemes in India or in South Africa, for example, that are being established now, or even some of these new insurtech players that are popping up that are serving a base of the pyramid who haven't been insured previously. So working with payers, trying to figure out and forge relationships with human-centered providers, like the examples just we heard about, patient advocacy groups that have not been really in the mix on these health systems conversations. And then lastly, a handful of donors that are willing to sort of take the risk and put in some innovation dollars to actually get this going. So that's one thing we've been doing, building partnerships. The second thing that we've been trying to work on is, how do you build the enabling environment for this sort of leapfrog to happen? And just two quick things there. One is, there's a lot of stuff going on in digital health, as in the rest of the world, but what's special about a place like India, for example, that has just set up this sort of digital health mission, is that there's like a unique opportunity to start building data systems, these new digital systems, and position them for a leapfrog. Can you imagine if you're starting from, not from scratch, but from an earlier base, could you build these data systems smart now? Another piece of the enabling environment is, what are the sort of knowledge products that could help providers, payers on the ground to start innovating on their own? The third thing that we're doing as a platform is really advocacy, telling the story of particular examples, but then could we actually, in the same way that this forum is, right, telling a story about what's possible. I'll just close with two quick lessons. One is, we've often talked about like volume versus value, but that's just not gonna work. In a place like where Nicole is in Kenya or in India, you just need a ton of volume. We just need more healthcare. And so it's less about the opposition and more about, how do you get a sort of a fortuitous cycle of both? And there's some amazing examples, even before this whole kind of value-based care ecosystem came about, a lot of innovators in the global south that actually we've learned from in the US and tried to replicate models that were really volume-driven, but achieving value through volume. So I just wanted to throw that spin there. It's a bit of a paradox or conundrum. The second one is, are we trying to standardize stuff, or are we trying to customize? A lot of the movement of value-based care has said, well, if you pay somebody and give the providers the flexibility to tailor care for their patients, that could be a good thing. Pay for the outcomes, don't dictate all the process. So that's on one end. On the other hand, there's this idea that, how do you scale if you don't standardize? And so that tension for me, I don't have an answer on that, but that tension is really alive, particularly in the context where you have a workforce that doesn't have as much training. So perhaps you need to standardize a bit more and need to provide a certain level of flexibility, but at the right level, where there's the decision-making capacity to really use that flexibility. So a handful of lessons. Over to you, Nea.
Wonderful. Thank you so much. Thank you for that overview and also some of the provocative questions and that you've raised. And I think the one regarding standardization versus customization, really something that we at ICHOM have discussed a lot as well. And I think it ties in nicely to the panel session early, the first one this morning with Dana Safran's words related to alignment versus innovation. There is a tension relating to how much you can standardize versus adapt to local situations. So wonderful, wonderful overviews of your various work. So maybe let me ask a question pointed towards Nicole and Bishnu. And it touches on what you all have mentioned, which is the potential for data, platforms, and digital technology in being able to measure outcomes and really drive value-based care. One of the challenges that we hear often about in resource-limited settings is challenges with technology, right? So it's anywhere from use of smartphones or availability of smartphones, as well as power interruptions when you're thinking about maintaining data and the capacity for electronic medical records. So my question is for both of you to speak to whether or what some of these challenges related to this you have faced and which are false and not relevant to your context, and where you have faced the challenges, how you have navigated them in a way that you're able to measure and use data as successfully as you've done.
Great. Thanks for that question, and let me start, and also recognizing some of the comments that Chin made, that indeed when it comes to value in healthcare in sub-Saharan Africa, it's about getting women to the healthcare facilities, because at the moment they're staying at home, they're not going there, and they're paying with their lives, which is a high cost to them personally, but it's a low cost to a financial system, which is such a devastating conflict, and a conflict we're trying to solve. The technology revolution is ongoing, and in fact some of the revolutions are taking place on the African continent. In Kenya, where I've lived for the past 6 years, mobile money, so money on your mobile phone that allows you to pay for services with a bank account, is used by almost every single Kenyan, and it's something whenever I travel to the Netherlands, then I'm always looking for my credit card because I'm so used to paying with my mobile phones. So the idea that innovation and technology innovation flies on a KLM flight from Amsterdam to Nairobi is long in the past, and I would argue that very often it flies another way around, because these countries are now on the forefront on developing innovative systems that disrupt and leapfrog the status quo. And the fact that almost every Kenyan now has a mobile phone, I think mobile phone coverage is more than 100%, because a lot of people have 2 mobile phones. That mobile phone, so when we think about digital revolution, we have used that mobile phone penetration to connect patients to a mobile health wallet, basically loading their entitlements to healthcare services on that mobile phone. So every time they go to a healthcare facility, they trigger that transaction. We can confirm that this woman really went to this healthcare facility receiving real care, and this monitoring along the care process with this mobile phone allowed us to do something that was unprecedented, whereas technology very often measures how many ANC's visits were taking place at a healthcare facility divided by how many women were seeking healthcare. But you don't know if everyone had sort of 2.5 visits, or some of them had 1 visit and some of them had 4 visits. And that translates a lot in if you have provided good or bad healthcare. So being able to track that from an individual basis, we've really seen that revolutionized. And women also taking that ownership and that pride of going to that healthcare facility. So what we've seen is that people sometimes overcomplicate technology, and everything needs to be connected with everything, and APIs, and before you know it, you never start. And we've used very simple mobile phone solutions, connected it to a very basic healthcare system at the healthcare providers, and every time the women go into the facility, it triggered that transaction. So we find that sometimes being behind in some of the technological revolution, it allows you to leapfrog that things. So we've definitely seen that this is possible. What we have seen, especially when it relates to using the ICHOM sets, is that you need to condense your questions, because there's only so many questions that you can put in a text message, or so many words, and then if a standard is too long, then it doesn't fit. But again, as I mentioned earlier, also some of the questions, And maybe to use a nice example, we've used the ICHOM sets to ask women about depression after giving birth, something that is completely not highlighted at all as a huge issue in sub-Saharan Africa. And one of the questions we asked is, who's taking care of your dog when you're not feeling well? Which is a very normal question to ask in my country because we have dogs as a pet. And we asked it the women and they started laughing and said, the dog is in the garden protecting my house. What do you mean who's taking care of it? The dog is taking care of me. So it's really an example of how you need to change that question. But if you build that into that mobile platform, I think many countries are ahead of what we can do in places like here.
Wonderful. And thoughts, Bachman?
Yeah, it's interesting times in India, for example, and I take this word from leapfrog. If you look at the world, Industrial Revolution started incrementally and went up. But presently, most of the developing countries, India included, there's an aspirational generation sitting there, the young generation, who want to move on. They don't want to look at the past, they're looking ahead. So technology has taken over. As is mentioned, everyone, about of the 1.3 billion people, about 800 million, 850 million have mobile phones. If you look at the last 2 years, when the pandemic hit, the CoWIN app was developed in India, and it has data of each and every patient who was vaccinated. Upwards of 2 billion plus have got 2 vaccine shots across the country, and the data is there. Before the vaccination started, anyone doing any RT-PCR test anywhere, in a government lab or in a private sector lab, there was accession number. Immediately the public health authorities get intimated. Because when you do the test, you have to give there's something called the universal ID called Aadhaar card we have. We have to show that, and only then the test is done. So automatically it is linked. You get a call. When I had COVID, I got a call from the health authorities, where are you? Because from the phone they can track also whether you are really sitting at home or you are moving about outside. So to that extent. So that is how technology has advanced. About 3-4 decades back, the former Prime Minister had mentioned that out of every 100 rupees, hardly 10 paise trickles down to the last mile, which is a very damning, and imagine from the Prime Minister this is coming out. So technology has overcome that. Now, every poor person, every middle class who are supposed to get any benefit from the government, the thing goes directly into the bank accounts. Nothing, there's no intermediary. Similarly, the health mission has been launched now. We call it the largest health insurance, and it is work in progress. Side by side, as you mentioned, a digital health mission is coming up, where it will be a standards data set for every patient who goes to whether it's to go to a primary health center, secondary or a medical college, or comes to a corporate private hospital, the data will be same. But that's a very important thing that's required. So if you have to leverage technology, as was mentioned earlier, what is the data you need to have? Because if 3 of us are sitting and we have different data sets, it will be very difficult to sort of come to a decision. So I think the technology enhancement is happening. And I think so it's a very nice thing to see that it's the developing countries who are leaping frog and taking the front line now.
Yeah. Thank you so much. I'm mindful of the time, so I'm going to ask one more question, then open it up. And I want to go back to what you mentioned, Shintan, which is the tension between volume and value, right? And I want to ask how you see us doing both in parallel, how you envision that being possible. And maybe to piggyback off that question, a provocative one, particularly that comes up with payers, and by payers I'm meaning the private as well as public, so government payers, where they're struggling with being able to have complete data for birth and death registration, struggling with achieving high mortality rates, and now you're bringing in to the targets and the goals, achievement of compassionate, patient-centered, high-value care. What are your thoughts on how that can be done, and what have conversations and insights working with payers been for you?
Yeah. Wow, okay.
It's a,
I mean, I'll just give you, just to anchor it in an example, there's a 5-year period where the Indian TB program doubled its spending, and in the same period, mortality doubled. And so spending doubling, mortality from TB doubling, it's obviously more complex, like what's going on there. But we're already sort of increasing volumes, but we're just not getting that much value from it. So I think this question about like, can we continue, can we afford to do this complex stuff now? You could flip it, obviously, and say, well, can you afford not to? And I think we're trying to, this is not for everywhere across every low and middle income country, but there's a handful of countries that we see are really well poised, where the supply side is not totally broken, that there's some risk pooling happening among payers. And in those examples, where they're already starting to channel more resources, that's where we want to start. That's a beginning of an answer.
Wonderful, thank you so much. And with that, we'd like to open it up to any questions from the audience here, and also if there's any questions virtually, please, Ali, share them. Go ahead.
We can kind of hear you.
Okay. Oh, there you go. I'm loud also. All 4 of you are extremely qualified to answer the question, so I'm going to let you fight for it, not assign it to anybody in particular. But working across continents entails working across languages. And this morning we talked about the idea of a harmonized term bank, but you have to translate that. To what extent is translation into other languages a hindrance or something that extends a timeline for implementation of standard sets in different countries?
Maybe Nicole, you can take that. And I think the question is speaking to both linguistic and cultural translation, which is what you've touched on.
So linguistic, you can translate, but we've actually done that in Kenya and Tanzania. Especially in Tanzania, the national language is Kiswahili. So most women will not be able to understand English. Very practically, this many words in English are this many words in Kiswahili. So you can translate it, it doesn't fit on a mobile phone. So that is where you need to be much shorter. And then the second part, which is the social barriers, I already alluded to with the example of who's taking care of your dog. We have seen that a lot of questions receive cultural context. And again, to stick with the issue of mental health, we all know it's a huge issue. Simply asking a woman that is living in the slums that may have received a baby because she was raped by someone, asking her, are you happy? Basically, they look around and they say, what do you think? Look at where I live. What do you think? I'm happy or not? Having said that, we've also seen when we started asking the questions, I was sometimes worried, are we not asking too much, right? Because some of the standard sets are about, you know, how do you experience sex after delivering a baby? Are you experiencing pain? Those are very personal questions. And we were afraid women would not answer them. And the response we got was, you are the first people that actually ask me how I am doing. And I feel so protected, I feel so part of a group. And that really brought tears to my eyes because we're starting to take care of a group of people who have simply been marginalized and forgotten in the past. What I think we need to be doing is, because it's very important that we have a standardized approach. My team here knows this, but I'm very passionate that we should never have poor man's choice standards, right? What outcome is the same whether you live in Boston, in Amsterdam, or in Nairobi. So what we need to do is somehow be able to set the intent of a standard as the most prominent. What are you trying to measure? What are you trying to achieve? As much as possible standardized, but where you need this translation because of language, because of social, cultural issue, have a team that monitors that and says, okay, this is the universal translation that we allow, and this is where you deviate to a point where we are starting to introduce poor man's choice outcome indicators, which we do not want, right? The same outcome indicators apply everywhere. So those are sort of my first thinking, how we should approach this.
Wonderful, thank you. Any other questions?
A small add-on, well, if there isn't one. Actually, what's harder than the language, I think, we can translate across language, translate across culture. It's where there are low expectations of providers, where you have no other choice but that free government facility. People don't, when you ask them, are you satisfied with care? 5 out of 5. And I think that's one of the toughest things that we've faced is, and so what I love about the mom care example is that you are part of this journey with the provider, and across that journey, you're sort of increasing the mother's expectations along the way. And so then when you ask them, are you satisfied, you're more likely to get some kind of feedback you can act on.
I have 2 points to make. One is on what he was mentioning about the insurance thing. So a lot of insurance providers are now starting to look at outcomes. This is, I'm talking about the Indian journey now, that they are looking at that. So that is one part of it. So it's interesting. And the government also, because of this universal health insurance that has been launched across the country, they are also looking at how do we put this in. So some things are coming in. And the other thing on this prompts, which I wanted to mention, is that when you started using our patient experience officers to elicit the prompt responses, and it is in the basic languages that they speak, because India has so many states, they have different languages. So it is in their language. The initial responses that we are getting from the patient and the relatives is pretty encouraging. It's early days, no doubt. Hopefully, next year or year after that, when we have a substantial data, I can share it. But this is the first time they are saying that after we are treated, people are coming and asking us, how are we? So how are we is a very important message that has gone out, and it'll crystallize.
Wonderful. Thank you. I'm going to repeat Stefan's words and say I'm seeing a big fat red 0 in front of me. And so I think we have to conclude the session. But I want to say thank you to our panelists. It was a very interesting, insightful, and riveting discussion. I wish we could discuss more and had more time to do so, but I hope you've been able to glean from the discussion some examples of what high-value care looks like, what the challenges and tensions there are in different contexts, and also names and faces of where you could look to connect and join forces in collaboration for what really is a global movement that we're trying to build. So with that, thank you very much for your time, and thank you to the panelists.
Appreciate it.
Good to meet
Thank you.
you. Good.
Thank you. Thank you very much.